Third nerve is one of the most interesting nerves that we ophthalmologists ever come across, and is certainly one of the most fascinating cranial nerves. Before we move on to its origins, let's first of all see what its functions are. Starting at the top, the levator muscle, the levator palpebrae superioris, is supplied by the superior division of the oculomotor nerve. The other muscle supplied by the superior division of the oculomotor nerve is the superior rectus, which has three main actions. Primary action is to elevate, the secondary action to intort, and the tertiary action to adduct. Whereas the levator muscle, of course, only has one action, which is to lift the lid, failure of which is called ptosis. Now down here on the bottom, we have the inferior division of the oculomotor nerve supplying the inferior rectus, the medial rectus, and the inferior oblique. These are all voluntary muscles, of course, and supply striated muscle. The inferior rectus has three main actions: the primary, depression; the secondary, extorsion; and the tertiary, adduction. The medial rectus only really has one action, which is adduction, and the inferior oblique has three main actions: the primary, extorsion; the secondary, elevation; and the tertiary, abduction. Here in the middle we see pupil. Pupil is mentioned because the Edinger-Westphal nucleus of the third nerve supplies fibers to the pupillary sphincter, which allow for accommodation of the ciliary body and for constriction of the pupil. These fibers have a ganglion on the inferior oblique branch, which is called the ciliary ganglion, and damage to this critical relay station can result in a dilated pupil in a syndrome called Adie's syndrome. Now, third nerve nucleus is fascinating because it isn't only one nucleus, it is a collection of nuclei which is spread along the midbrain area and are grouped into groups depending on the muscle that they supply. First of all, the levator is supplied by a paired central nucleus, which is absolutely fascinating, whereas the superior recti are supplied to the contralateral superior rectus muscle, so damage to one center can result in a contralateral elevation deficit, and all others are supplied ipsilaterally. Now, the interesting thing with the medial rectus nuclei is that they are quite closely linked. In fact, they are right next to each other, right in the midline, so lesions can affect both together, resulting in a so-called webino, or wall-eyed bilateral internuclear ophthalmoplegia. The nerves are grouped together into a fascicle which passes through the midbrain, and the first port of call is the red nucleus. As it passes through the red nucleus, damage here can result in a syndrome called Benedict syndrome, where there's a third nerve palsy and a contralateral hemitremor. This can be caused by stroke, multiple sclerosis, or neoplastic lesions. Further down then, the fascicle moves through the motor functions to the body, and damage to the third nerve in this area can result in a contralateral weakness or hemiplegia, and this is called Weber's syndrome, caused by the same sort of pathologies. The nerve then exits the midbrain, passes into the cavernous sinus, where it runs along with other cranial nerves, in particular the fourth, the fifth, and the sixth nerve. This can result in a multitude of interesting anomalies and can sometimes be called the cavernous sinus syndrome. Vascular disorders predominate in the causes of pathology in this area. The nerve then exits the cavernous sinus, passes through the orbital apex into the orbit where the space is tight, and Tolosa-Hunt syndrome can be caused by any pathology affecting the nerve in this area, which again, along with the optic nerve, has multiple ramifications. As it enters the orbit, then orbital disease, whether it be inflammatory or neoplastic or caused by thyroid eye disease, can cause limited nerve palsies depending on where the pathology is located. And again, just an isolated third nerve palsy without it being associated with any other either systemic or local effects can be caused by raised intracranial pressure, which itself can be caused by compression or ischemic events. This makes this particular nerve one of the most fascinating cranial nerves, and certainly one of the most detailed that we ophthalmologists ever encounter. Thank you for listening.